Hello everyone and welcome back to the Deep Dive. Today we're tackling a topic that feels, incredibly mundane, right up until the moment you're the one suffering through it. We're looking at that specific throbbing misery where your face feels like it's being crushed from the inside out. We usually just say stuffy head or sinus headache.
Yeah.
But today we're actually digging into the biological plumbing behind it all. We are diving into sinusitis.
And it's a condition that is just so common, yet really surprisingly misunderstood. And actually, looking at the literature we pulled for this, we probably need to start by correcting the terminology.
Oh, right. I noticed that in the papers. The clinical guidelines seem, pretty insistent on using the term rhinosinusitis.
Yeah, and it sounds like a small thing, but it's actually a crucial distinction for understanding how this all works. Rhino refers to the nose, and sinusitis obviously to the sinuses. The data emphasizes that inflammation of the nose, rhinitis, it nearly always precedes the sinusitis.
Because they aren't totally separate systems, right?
Exactly. The mucous membranes, the lining of your nose and your sinuses, are contiguous. They're connected.
This is like the same wallpaper.
It is. It's the same wallpaper lining your nostrils and these hidden caves in your skull. So if your nose is inflamed from an allergy or cold, your sinuses are probably involved too. It's a package deal.
That makes perfect sense. It's one big, unhappy neighborhood on your face. So our mission today is to explore these hidden caves. We want to understand why they get blocked, figure out the difference between a virus and a bacteria, which the sources say is the biggest challenge, and figure out when you actually need antibiotics.
And that last point is so critical because, as we'll see, the stats show we're often reaching for those way too early.
Okay, so let's set the landscape. We're talking about cavities in the skull. I think most people know they have sinuses, mainly because they hurt, but they might not know where they are.
Right, it's a literal map of pain. You have the maxillary sinuses, which are the big ones in your cheekbones, and then the ethmoid sinuses, which are like a honeycomb structure right between your eyes.
That honeycomb description, that really stuck with me. It explains why the pressure feels so spread out there.
It's a complex little labyrinth. Then you've got the frontal sinuses up in your forehead, that's your classic throbbing headache spot. And finally, the sphenoid sinuses, which are way back, deep behind the nose.
Almost in the center of your head.
Yeah, almost.
So it's quite a network. And looking at the clinical definitions, the calendar, the timeline, seems to play a huge role in diagnosis.
The timeline is everything. The sources break it down into 3 distinct categories based purely on how long it's been going on. First, you have acute. This is an infection that lasts up to 4 weeks. But the key here is that it ends with total resolution. You get sick, you get better.
Okay, so that's your standard bad month. What if it drags on?
Then you enter the subacute phase. That's persistent symptoms for more than 4 weeks, but less than 12.
And if you hit that 3-month mark,
That's chronic,
Yeah.
12 weeks or more. And biologically, chronic sinusitis is a totally different beast. It often involves different inflammatory pathways, and it needs a whole different approach.
so we have the locations, we have the timeline, but here's the aha moment for me. How does a healthy air-filled sinus actually turn into a sick fluid-filled one? The papers describe this 3-pillar system for sinus health.
Well, to understand the failure, you have to appreciate the design. A healthy sinus depends on 3 things working perfectly together. First, you need mucus of normal viscosity and volume.
Goldilocks mucus. Not too thick, not too thin.
Essentially, yes. Second, you need normal mucociliary flow. Think of these as microscopic sweepers or cilia lining the caves. They're constantly beating to sweep the mucus out.
So they're the janitorial staff keeping things moving toward the exit.
Precisely. And the third pillar is open sinus ostia. The ostium is the drainage hole.
If the door's shut, nothing gets out.
Exactly. So you need good liquid, a working pump, and an open drain.
And when one of those breaks.
That's when you get rhinosinusitis. It's a vicious cycle. Usually it starts with a viral infection or an allergy which inflames the mucosa.
So the lining gets all puffy.
Right. And when that happens, the secretions get thicker, the viscosity increases. And because it's so thick and inflamed, those little sweepers, the cilia, they just stop moving.
The janitors go on strike.
They're rendered immobile.
Yeah.
And then the ostium, the exit door, gets blocked by all that swelling. Now you have a closed room filled with stagnant, thick fluid. The oxygen gets absorbed, creating negative pressure.
Which does what? Pulls more fluid in?
Pulls even more fluid from the tissue into the cavity because of stagnant swamp.
And that's when the bacteria finally move in.
Well, the bacteria might already be there or they migrate in, but now they are trapped and they just proliferate. The source mentions the usual suspects here: Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
A real rogues gallery of microscopic villains. But here's where the data got really interesting to me. The source notes that viral rhinosinusitis happens up to 200 times more commonly than bacterial.
200 times, that's the ratio.
That is just a staggering difference. So the vast majority of the time, when we say, I have a sinus infection, it's actually viral.
Correct. And that means antibiotics, which kill bacteria, are useless for most of these cases.
So aside from just catching a cold, what else sets us up for this? The source has this predisposing factors list that is, pretty wild. There's the obvious stuff like allergies and smoking. But then there's some really specific anatomical things.
This is where we get into the structural plumbing issues. A deviated nasal septum, or DNS, is the one most people have heard of.
When the wall between your nostrils is crooked.
Yeah, it narrows the airways. But the source also points out some fascinating anatomical oddities. Things like Haller cells.
Haller cells. It sounds like a prison block.
It can feel like one for your sinuses. A Haller cell is an anatomical variant. It's an extra air cell located just below the orbit of the eye that can encroach on the maxillary sinus drainage pathway.
So you could just be born with a slightly misplaced air pocket in your skull that dooms you to sinus infections.
Yes. If it's enlarged, it physically blocks the drain. There's also mention of concha bullosa. This is when the middle turbinate, one of those shells inside your nose, has an air bubble inside it. It balloons out.
Wow, so it really is just a plumbing issue.
Completely. And then you have the lifestyle factors. Smoking, air pollution,
Yeah.
even cocaine use is listed because of the damage it does to the nasal lining.
And I saw dental procedures on the list too. I guess because the roots of your upper teeth are right there.
Exactly. The floor of the maxillary sinus is very thin. A tooth infection or an extraction can breach that floor and introduce bacteria directly. Oh, and one more surprising one: scuba diving.
Ah, the pressure changes.
Barotrauma. If you descend and can't equalize the pressure in your sinuses, the mucosa can swell instantly.
Remind me to cancel my scuba trip if I have the sniffles. Okay, so let's say you're ticking these boxes, you feel terrible. How do we diagnose this? The source breaks symptoms down into major and minor categories.
This is a very helpful framework. The major symptoms are the heavy hitters: facial pain or pressure, nasal congestion, and here's the big one: purulence.
Purulence, that's the polite medical term for pus.
Essentially, yes, thick, discolored, opaque nasal discharge. Also on the major list are hyposmia, a loss of smell and fever,
Okay, and the minor list.
headache, bad breath or halitosis, fatigue, dental pain, cough, and ear pressure. The idea is that if you have a couple of majors or a mix of major and minor, the likelihood is high.
Now, if I go to the doctor, what are they actually looking for?
Well, the physical exam is important, but they're looking for specific signs. The source highlights that the sign with the highest positive predictive value is that purulent nasal discharge.
So not just clear, runny stuff.
No, clear usually suggests viral or allergic. We're talking colored, opaque discharge. They also look for tenderness when they tap on the sinuses, and sometimes periorbital swelling puffiness around the eyes.
Okay, now here's where we get into some myth busting. I think a lot of patients expect, a swab or an x-ray to prove they have an infection. but the sources shut that down.
They really do, and this is a major disconnect between what patients expect and what's best practice. Let's talk about cultures first. Swabbing the nose is generally not recommended.
Why not? Wouldn't that tell you what bacteria is there?
It tells you what bacteria is in the nose, but that has a very poor correlation with what's actually deep inside the sinus causing the problem.
So it's a different neighborhood.
Completely. A swab just gives you bad data. You might end up treating a bug that isn't even the culprit.
That's wildly counterintuitive. What about x-rays? I feel like I've had sinus x-rays before.
They used to be common, but the current guidance says not to use them routinely. An X-ray can show fluid levels short, but here's the catch. It cannot distinguish between viral fluid and bacterial fluid.
Right, fluid is just fluid on an x-ray.
Exactly. So if maybe 98% of cases are viral and the X-ray just shows fluid, it doesn't help me decide about antibiotics.
So when do you bring out the big guns, like a CT scan?
CT scans are reserved for complications. If the infection's spreading to the eye or the brain, or if it's a chronic case that isn't responding. But for your standard, I've been sick for 10 days, patient. No CT, no MRI.
Okay, so we've diagnosed it. We know it's likely viral, but maybe bacterial. Now we fix it. And I saw one statistic in the management section that just blew my mind.
I think I know which one you're talking about.
70% of cases will resolve spontaneously without antibiotics.
That's the headline. Even if it is bacterial, your body is incredibly good at clearing these infections.
So before we rush to the pharmacy, what is the supportive care protocol? What can we do at home?
It's all about symptom management and helping drainage. First, analgesics and antipyretics, like Tylenol or Advil for the pain and fever.
Okay.
Step 2 is getting things moving. Saline irrigation, like a neti pot and steam inhalation. This helps thin that mucus viscosity we talked about.
And what about decongestants? Those sprays can feel like magic.
They can be helpful, but the advice here comes with a giant warning label. Topical decongestants should be for short duration only, 3 to 5 days max.
Why is that?
Rebound congestion. If you use them for too long, your blood vessels become dependent on them. When you stop, they swell up worse than before.
Okay, noted. Short term only. And steroids.
Topical corticosteroids are listed as controversial but may help. They reduce inflammation, which might open the ostia, but the evidence varies.
All right, but let's say we're in that unlucky 30%.
Right.
Or we've hit the criteria for acute bacterial sinusitis. We need antibiotics. What's the weapon of choice?
We use a ladder approach. We don't start with a nuclear option. The first line defense is amoxicillin. The source suggests 500 milligrams 3 times a day for about 10 days.
Just straight amoxicillin.
Usually, yes. It's narrow spectrum. It targets the likely bugs without nuking your whole system. If you're allergic to penicillin, the alternatives are doxycycline or trimethoprim sulfonethoxazole.
And what if that doesn't work? The bacteria are tough.
Then we move to the second line, the heavy hitters.
That's augmentin, right?
Correct. Amoxicillin clavulanate. The clavulanate part disables the bacteria's defense mechanism. Or we might use cefuroxime. If you have an allergy and need second-line drugs, then we look at things like levofloxacin or azithromycin.
That's a very structured escalation.
Precisely. Because every time you use the heavy artillery, you risk creating more resistance.
So let's recap this whole journey. We start with a blocked door, the ostium. The cilia stop sweeping, the fluid gets thick, and we get that awful pressure. Most of the time it's a virus, and 70% of the time, our body handles it with some steam, saline, and rest.
But when it drags on, or when the symptoms match that major criteria, specifically the purulence, we consider that it might have become bacterial. We confirm with a good physical exam, not x-rays, and only then do we consider something like amoxicillin.
It really makes you look at your own face differently. It's not just a block of bone. It's this complex ventilation system.
It is. And if we connect this to the bigger picture, it highlights this fascinating interplay between macrostructure and microbiology. Think about it. You might have a tiny anatomical cork, Bowler cell, or a bent septum that you've had since birth. It's a structural issue.
Right. It's just how you're built.
But it takes a microscopic invader, a virus that's hundreds of times smaller than a bacteria, to exploit that structure. The virus creates the swelling that suddenly makes that Howler cell a problem. It's the interaction between your specific body and the environment that causes the disease. Yeah. And that's why telling viral from bacterial is so vital. If the problem is a structural blockage inflamed by a virus, throwing antibiotics at it is like trying to fix a plumbing clog with a grenade.
It misses the point entirely.
Exactly.
That is a great way to put it. Treat the cause, not just the symptom. Well, next time I have a stuffy nose, I'm definitely going to be visualizing those poor cilia trying to do their job.
Just give them some steam and hydration, and they will thank you for it.
Will do. Thanks for listening to this deep dive on sinusitis. We hope you breathe a little easier today.
Take care, everyone.
See you next time.